Thank you, Serge, for that very excellent update on the JAK2 inhibitors. I want to make sure that I've acknowledged the magnificent efforts of David Booley in really helping put this conference together. As you heard, he formed this patient committee and spent a great deal of time in obtaining their opinions and helping me put the program together. One of the subjects that he presented as a result of this was the topic of my presentation is, can we prevent progression of the MPNs with interferon, which was a subject that I wasn't sure that I wanted to present in front of my colleagues, and notwithstanding the audience, but he insisted, and so I thought about this a great deal, and I thought that it would also give us an opportunity to express an alternate approach to the MPNs. So may I have the first slide? So the issue really depends upon what we are referring to. And it really depends upon the disease. It depends upon various contributory factors. For example, we know in patients with polycythemia or in essential thrombocythemia that coexisting diseases such as diabetes, hypertension, cigarette smoking, and other ancillary illnesses may play a role in the thrombotic events that characterize this illness. Likewise, in polycythemia vera, the same factors are relevant as in essential thrombocythemia, but also the number of phlebotomies, which has never been sufficiently examined in the literature, plays a significant role, because if a patient requires 10 phlebotomies a year, that patient is biologically different, in my opinion, from someone who requires only 2 or 3. The range of phlebotomies in our studies at Cornell in patients prior to any definitive therapy has been from 1 to 25 per year. The average in patients in general is about 6 to 7. So it's obvious that if you compare a patient who is taking 15 phlebotomies a year, they are biologically different than a patient with 2 or 3. And maybe that is related to some of the gene expression profiles that Dr. Spivak talked about earlier, and we'll ask him that question specifically later on. The last is, in primary myelofibrosis, we believe that notwithstanding the really important advances that the JAK2 medications have made in the treatment of these disorders, that this is really at variance with how we approach cancer in general. We don't treat a lady with a lump in her breast for breast cancer when it's metastatic. We don't treat a man with prostate cancer when it's advanced. We don't treat lung cancer when it's metastatic. We try to pick it up on a routine CAT scan. There's really no reason that these diseases are different if we consider them a low-grade neoplasm, and thus the treatment of these illnesses might be best treated earlier rather than late. Now let's look at each of the 3 diseases in the category and start first with essential thrombocythemia. One of the most important contributions that have been made in the recent years has been that by our hematopathologists in Europe, and they have pointed out, what happened to, which one of my predecessors has walked off with the pointer? Oh, there it is. We usually have a supply of 10 or 12. No, here it is. They have pointed out that the new recommendations of whether or not patients with essential thrombocythemia, and somebody already asked me about this morning, really should be based on what the Marrow findings are at the initial diagnosis, because we have found, and others in Europe, that sometimes we are dealing with a very early stage of myelofibrosis, and that, in fact, has a very different prognostic finding than patients with true essential thrombocythemia, as you'll see in just a minute. And therefore, we believe that all patients with essential thrombocythemia who have the phenotype of ET must have a biopsy at diagnosis to exclude primary myelofibrosis and to establish the degree of reticular fibrosis, which we want to follow over the course of years, and to determine if any reticular fibrosis is present. And this is shown in a paper from our Italian friends, Dr. Barbui, who will be here tomorrow, that if you look at patients in the top two lines, the top line is patients who truly have on marrow biopsy the hematologic and pathologic characteristics of essential thrombocythemia. And in a light blue line, you'll see that those patients have an essentially the same survival as patients of the age-matched controls in Europe, as marked in E. The lower line, however, are those patients who have very early myelofibrosis, and you can see that they have a survival time that is a little bit different than those patients with true essential thrombocythemia. So we believe that every effort should be made to establish a critical diagnosis of the myeloproliferative disorders when the patient is first seen. And I have a slightly different viewpoint of those hematologists who believe that there's a lot of transitions between these diseases because I believe that they're not properly diagnosed from the outset. So there is no data as yet that early treatment with interferon of patients with essential thrombocythemia with any drug will change necessarily the survival time. And furthermore, most patients, as you know, with this illness don't require any treatment except perhaps for a low-dose aspirin or other anticoagulants that Dr. Wexel will talk about. On the other hand, they can be treated with drugs such as interferon if there are thrombotic problems that develop during the course of the illness. Let's look, however, at the situation with primary myelofibrosis, which we all agree is a much more significant illness. You already heard that there is now a scoring system which is really of interest more to those of us who participate in these drug trials rather than to the patient. But basically, these scoring systems are based upon a patient's age, constitutional symptoms, the degree of hemoglobin, the white count, the platelet count, and most recently there has been additional parameters such as the need for transfusions or not, and whether or not patients' bone marrow show abnormal chromosomes. But for the purpose of this discussion, we can divide these patient characteristics and hematologic characteristics into four groups: a low-risk group that has no risk factors, a intermediate 1 group that has 1, a intermediate 2 group that has 2 to 3, and a high-risk group that has 4 or more. I think I'll lean this way a little bit to give those folks on this side the value of the pointer. We began a program, it's an early program at Cornell, using very low-dose interferon. And the reason for this is based upon the fact that interferon has a lot of specific actions biologically that may interfere with megakaryocyte activity, and I'll talk about that in just a moment. But the essence of it is to begin with very low dose. As you can see, 0.1 to 1 million units 3 times a week if we're using interferon alpha-2b, or if we're using Pegasus, a very low dose beginning with 45 micrograms subcutaneously once a week. Some of our patients, because of insurance reasons, received different types of modalities, and I would take this opportunity to point out that there's absolutely no evidence that any of the interferons have any difference with respect to qualitative change with regard to what the hematologic response is. It's really a question of side effects and a question of toxicity. And the dose was adjusted based upon the responses and tolerability. So the median time to treatment effect in patients who we treated early with this disease, that is either low risk or intermediate 1, was a median time to response of about 1.5 years. And it is of some interest that the change in fibrosis in the bone marrow that Dr. Verstovsek reported also took a lot of time, and I think that has a biologic basis for it because these changes in the megakaryocytes and related factors take time in order for them to be affected. And the median duration following a documented response has been substantial, as you can see on the screen. Now, we use the spleen as a marker for response, and Dr. Verstovsek showed patients who have really large spleens. These are the patients that are not candidates for interferon therapy because we know that advanced patients with myelofibrosis or advanced patients with extensive fibrosis with polycythemia do not respond to interferon therapy because the doses that have been used have been too high and therefore they don't tolerate it. So you'll notice that on the left-hand column, we have the staging system in which we find that patients either had no enlargement of the spleen or slight enlargement of the spleen that's just below the costal margin, maybe a finger breadth or two, moderately enlarged splenomegaly, as you can see, and then massive splenomegaly if it was larger than 5 centimeters below the costal margin. And this was the number of patients who had these findings at the time of diagnosis, at baseline, as shown in the middle column, and then at last follow-up. And the two important findings that I want to emphasize is the fact that those patients who had no enlargement of the spleen at diagnosis or only slight enlargement maintained that improvement, whereas those patients who had markedly enlarged spleens continued to have markedly enlarged spleens and really did not show significant improvement at all. And this is shown diagrammatically in this slide, I'll turn here, in which you can see the size of the spleen shown on this axis and duration on this axis. And these patients who had very big spleens did relatively poorly using this interferon therapy as a marker, whereas those patients who had smaller spleens or no splenomegaly maintained that improvement over a period of time. And here you can even see some patients with just modest enlargement of the spleen have significant reduction in spleen size. So with all this attention to splenomegaly, these effects that we see in early myelofibrosis is of some significance with respect to therapeutic response. Now, this is a normal biopsy, and just for a standard of orientation, the white dots are really fat globules that get washed out in the preparation, and the other cells that you see here are normal hematopoietic cells, both red cells, white cells, and platelets, and megakaryocytes, that big cell in the center. This is a patient who we treated who had myelofibrosis, and on the right side of this slide, you can see some residual hematopoietic tissue, and this is significant fibrosis. And I will point this out again for the folks on this side. This is a residual hematopoiesis on the right side of this panel, and this is extensive fibrosis. And this is the response 5 years after interferon therapy, where there's absolutely normal marrow with restoration of normal architecture. And the cells, which we think are the troublemakers that Dr. Crispino mentioned, in passing these big, giant megakaryocytes, which are crushed and deformed, and you can see these dark dots, which we call the nuclei of the cells. They become restored to normal, so that this is not just a coincidental finding. There's something that interferon has changed with regard to the biology of the disease. And most importantly, that this fibrosis that characterizes this disease, which we would score as a reticulin of 2+, has now gone back to normal. So if we look at our patients, the 32 patients that we have treated with myelofibrosis, you can see that we've had 3 patients who have had an absolutely complete morphologic remission. There have been a number with partial remission as defined, some with clinical improvement, and others with stabilization. Of course, unfortunately, about 20% of the patients progressed. But overall, nearly 80% of the patients to date have either had stability or improvement of their illness, and to date, that represents a really significant therapeutic advancement in the treatment of relatively early myelofibrosis. And as you know, in the JAK2 trials, only about 30 to 40% of patients have responded to JAK2 inhibitors. So we believe that the early intervention of this illness really requires more thorough evaluation. And indeed, a phase 3 trial, because my colleagues say, well, you know, this is just a single-arm study, with all that implies, really requires further evaluation. Now, toxicity should always be mentioned, and even with low-dose interferon, some patients complain of aches and body pains. We believe that can easily be handled with salicylates or Tylenol, low-dose aspirin, etc. Sometimes we see changes in the hematopoietic counts, which require some dose adjustment. And sometimes there are more serious side effects, such as diseases of autoimmunity, hyperthyroidism, or lupus-like syndromes, which require discontinuation of the drug or lowering of the dose, and that occurs in about 10 to 15% of patients. But this is dose-related, and usually it can be managed. So let's look at the situation in polycythemia vera, because this is a disease which I think interferon plays a particularly important role, particularly since our colleague in France, Dr. Kalajian, reported changes in JAK2 going down to 0 in patients he treated with Pegasus, the long-acting interferon. And this drug has particular interest in PV because it is a drug that has specific biologic effects. It is a drug that it will affect megakaryocytes. It affects cell cycling. It affects JAK-STAT signaling, and most importantly, it has been shown just this last year that it affects PV stem cells. This was presented at ASH, and thus there's a real significant biological basis for its use. And again, this is the data with respect to the importance of calibrating what are the phlebotomy requirements that a patient has, because not necessarily do all patients require interferon if their phlebotomy requirements are low. But if they're high, we believe that this drug should be considered. Now, this is a slide that Jerry Spivak published some years ago, emphasizing the fact that the viscosity of the blood goes up logarithmically as the hematocrit rises. And I'll show it on this slide too. As the hematocrit goes up, the viscosity or the thickness of the blood rises logarithmically. So the mainstay of therapy is to get the phlebotomy, to do phlebotomy so that the hematocrit is restored to less than 45% in men and 42% in women. And we were very pleased that this past year an Italian group confirmed what we have been preaching for many, many years, since the days of the old polycythemia vera study group. So phlebotomy has historically been, as many of you know, a mainstay of treatment for many, many hundreds of years. Unfortunately, it probably led to the death of our first president, because it was pointed out that his doctor had bled him by 50% of his blood volume, and he died of suppurative laryngitis, which was not helped by the fact that he was so anemic. So therefore, phlebotomy is not the only method of treatment by far, and we know that it's unacceptable for the majority of patients because they do develop significant iron deficiency anemia, and although the red count can be restored to normal, they become significantly iron deficient, and this has its own consequences. So there's poor clinical tolerance, and there are frequency of vascular complications that are associated with phlebotomy because the platelets get activated as the blood is being flowed into the phlebotomy bottle. I mean, the bone marrow thinks that there's a hemorrhage, and so platelets become activated. And therefore, there was a need recognized for some form of marrow suppression, and to save time, it's unfortunate that the most common form of marrow suppression is used today is hydroxyurea. Now, this is data that has been known for years, that even in previously untreated patients, it's unsuccessful in 27%, or around a quarter of the patients, and in previously myelosuppressed patients using other drugs, it's unsuccessful in about 40% of patients. And so there is a study that the Myeloproliferative Disease Research Consortium that Ron Hoffman is chairing that is trying to really sort out and quantify the more recent data comparing high-risk patients with hydroxyurea against interferon. But I am talking about the early untreated patient, particularly those who are young, who should not be treated with hydrea for the reasons that I mentioned. And they are associated with considerable side effects, including these terrible ankle ulcers in a patient who is undiagnosed for about 7 months, because most dermatologists aren't familiar with this picture. So the interferon therapy that we use, again, is in the myelofibrosis patients, very low dose, beginning with 100,000 to 1 million units 3 times a week, 45 micrograms of Pegasus once a week, if the insurance companies will pay that. We have no problem in New York State because there is a law that says one has to pay the patient for insurance drugs if, in fact, there are more than 3 reports in the literature in reputable journals testifying to that fact, and there have been so many papers regarding the use of interferon that there is no problem in New York whatsoever. So this is a progression-free survival, that is a freedom from any kind of thrombosis that was seen in our first 55 patients. This is really a remarkable finding. As you can see, nobody had any kind of thrombotic event. That's that big line on the top, as you can see here and here. And when we submitted this paper to the editor some years ago, he said, well, we hope you didn't make this up. And I said, well, we really didn't. And that's the data. And then our friends in France published their data. It's exactly the same. And so has it been from Scandinavia. So whether or not it's the meticulous attention to phlebotomy or the effect of interferon on the vascular lining, the endothelial cells, it could be a combination of both. But it is no question that this drug really prevents the thrombotic events that we see in patients otherwise treated with hydrea or other myelosuppressives. So here is the bone marrow biopsy, again, that we showed earlier. The fat spaces shown in white, the big cell here, the troublemaker cell, the megakaryocyte shown here. This big guy in the middle, showed on this side, that big cell in the middle. This is a patient who had a 100% cellularity in the bone marrow. That's how you can see how engorged the bone marrow is, chock full of cells, and now you can see how many of these big megakaryocytes are present in the bone marrow. That's the cells we believe are responsible for the subsequent development of myelofibrosis. And this is a patient who, in fact, developed myelofibrosis 7 years after phlebotomy. You can see the distortion of the marrow. This is the grade 2 to 3 reticulin. This is a patient who also had this blue material I'm showing from my colleagues. That shows a lot of collagen, and I would emphasize that these patients did not have a lot of the so-called changes in the peripheral blood or significant splenomegaly. So these findings in the bone marrow can be very capricious, and unless one is very alert and is very organized to doing bone marrow's frequency, these kind of changes will be missed. And therefore, as Dr. Verstovsek mentioned, the staging systems that have been in use are really already out of date, although they've been published in the last couple of years, because they did not take it into account bone marrow findings or degree of splenomegaly. So those staging systems are completely incorrect. And this is the bone marrow 3 years after interferon back to normal. And this is the reticulin back to normal. And so in the last few minutes, how about the molecular changes with PEG interferon? This created a great deal of excitement because, as you heard, the JAK2 V617F abnormality is central to all of the myeloproliferative diseases, and it was reported by our colleagues in France that 90% of the patients with PV had a dramatic change in JAK2 levels and became undetectable in 24%. And also, Serge's group in MD Anderson reported an undetectable number in 14% down at MD Anderson. Well, we looked at our studies and found that, in fact, that we couldn't correlate the change in JAK2 in that 49 of our patients. And this is a bigger series than what was reported previously from France. And this may be due to the disease severity because they treated very early patients, whereas we treated patients who had the disease longer. It may be due to the time of diagnosis. And we had less toxicity than they reported, and then we used lower doses. So we believe it's preferable to maintain a complete hematologic response regardless of what the JAK2 expression may be, because basically we're physicians and we treat patients, and we shouldn't just treat an arbitrary selected molecular marker. And this is emphasized by the fact that, as you already heard from Dr. Crispino and Ron Hoffman and Jerry, that there are other mutations involved in these diseases, particularly TET2, so that by just aiming for JAK2 V617F, one may be overlooking other important mutations that aren't affected basically by interferon or not. We just don't know. So we've come a long way from the time we used leeches, and we treated President Washington, unfortunately, to his death. And can we prevent progression in the MPNs? We believe so. And to date, we believe at Cornell that interferon is the best treatment option in PV when used early stage disease. It's supported by identical data in France and in Sweden, where it is forbidden to use drugs such as hydroxyurea and alkylating agents. It may also be true to a lesser degree in primary myelofibrosis. This certainly needs to be confirmed. And it may be very effective in ET, and we certainly use it in women who are pregnant and require dose-lowering platelet treatment, but the great majority of patients with this disease don't require anything, as you can see here. So with that, I'll leave you with the concept that earlier may be better. Thank you.